With neurointerventional surgery, it's one of those fields that's really high risk and really high reward. So the majority of patients that I treat, especially in the hospital, tend to be emergencies. For example, last year we did almost 400 stroke thrombectomies. And what that means is I'm actually going in to a patient that's having an active stroke, and really one of the big strokes, the ones that can leave patients they either pass away from it or they end up dying in a nursing home because they can't take care of themselves. And for us, what I do is I go in, I try to take the clot out of either the neck or in the brain, and in doing so, reverse a lot of the stroke that they're having and saving a lot of brain. And if we look at our data, somewhere between 30 to 50% of patients from what I do are independent at 90 days, which is just astronomical. It's just, to put this in perspective, before what I do existed, that number was less than 7%. And so you're taking some of the worst strokes that have ever happened and being able to reverse those symptoms given enough time. When we look at stroke intervention, typically most hospitals will call us and say, hey, I have a patient here with a large vessel occlusion diagnosed on CT. Can we send him over to you? We'll say, absolutely, send him over. And more often than not, we send a helicopter, pick him up. The helicopter arrives at our hospital, the whole round trip probably taking about 45 minutes to an hour. We have it dialed down pretty well. Once they get into the procedural area, I have a big team. And additionally, our techs and nurses who can prep, drape, and get the patient ready, intubated, all within under 10 minutes of patient arrival. And from there, I take over, I access the artery in the leg more often than not, and then navigate a catheter, a large tube, all the way up to the clot interface. Once we get to the clot interface, I essentially hook it up and suck the clot out. Overall, my median time for these procedures is probably no more than 10-12 minutes from groin to reopening the vessel. And in doing so, we can reduce that stroke burden significantly. A lot of patients may even improve right there on the table.